Before getting to advanced disease, and I'm not going to talk about radical prostatectomy and known metastatic disease, primarily just clinically localized high risk. But before getting to that, I thought I'd go through basically the last 20 years in a few slides, not multiple slides, of how the role of radical prostatectomy has changed. This is not a techniques talk. It's just how we've utilized radical prostatectomy in the management of men with prostate cancer. So prior to the 1980s, we really didn't perform radical prostatectomy often at all, certainly from a retropubic standpoint. There was little understanding of the pelvic anatomy. These surgeries were considered, in the words of an older anesthesiologist that I've chatted with, bloodbaths. He said they would put towels under the doors because there was so much blood it would leak out. And it wasn't done very frequently. The patients essentially all experienced erectile dysfunction. There was no understanding of the anatomy. Many men experienced urinary incontinence. And importantly, these were clinically not biochemically detected cancers. So cures were infrequent. We were operating, or in those days, if one chose to operate, it really was on bulky disease. So it wasn't a procedure that was used frequently. What changed were two things, and you can say these were advances, at least the first one, maybe not, in terms of screening, but certainly there was the development of the PSA test. It was originally described by Albin in the early 70s in seminal fluid, and then by Wang in the late 70s. And in the 80s, it started to be used in the monitoring and then the detection of prostate cancer. In addition, at about the same time, anatomical studies were done, which really defined periprostatic anatomy. I think most of us are familiar with this slide. The incidence of prostate cancer jumped incredibly in the mid to late 80s. These were now biochemically detected cancers, not clinically detected cancers. And essentially anyone that was considered to have an elevated PSA test underwent a prostate biopsy. And, you can see the curve. Many hundreds of thousands of men were diagnosed with prostate cancer over the years. And the other critical event that occurred about simultaneously were the anatomical studies by Walsh and Donker. Dr. Walsh appropriately gets recognized primarily for cavernous nerve potency-preserving radical prostatectomy, but I think the venous anatomy description was far more important because it allowed the operation to be performed, still a lot of blood loss, but it could be performed far more safely, and that improved outcomes. So the surgery could be done safely. So the result was that we were finding these prostate cancers at a much earlier stage. So the cancers were curable, if you will, and the surgery became far more doable in terms of outcomes. And so the result was that we were now identifying a lot of men with low-risk prostate cancers, all of whom were treated. And the dogma of the day was that surgery should be used in low-risk patients because those are the ones that we cure, so we get good oncologic outcomes, and they were also the patients that were most suitable for bilateral nerve sparing. So you could improve functional outcomes. Now, the bar was low. We used to have 0% potency back when, but we improved. And most of the other men were sent to radiation therapy. And that's how, Dr. Walsh, we didn't know back then, but that's how Dr. Walsh made his name. I mean, it was the anatomical studies and operating primarily on low-risk patients. So more data became available, and the utility of treating all men with a PSA-detected cancer was starting to be questioned. And we had longer-term studies looking at the natural history of men, primarily men who had undergone a TURP, and we had found a small amount of Gleason score 6, and they weren't treated. And what happened to them oncologically? And this is one of many studies. This is from Peter Albertson and his group in Connecticut. And again, you can tell it's older because it includes Gleason 5 to 7. These are men over the age of 65. But if you look at the clinical T1C, so PSA-detected cancers that were Gleason 5 to 7, the chances of dying of prostate cancer, which is the dark gray component, if you were, 65 and older, was quite low. And these were patients who received no treatment. So the dogma of the day, treat everyone with a low-risk prostate cancer, was certainly appropriately questioned. And other studies, Lori Klotz, the group at Hopkins, some of the work at Baylor and then Memorial, led to the appropriate adoption of active surveillance for men with low-risk disease. And surgeons needed something else to do, so we started to operate on intermediate and some high-risk cancers. But most of the high-risk disease was still sent to radiation oncology because those are the patients that failed. So what changed? Again, more information became available. Randomized trials, the PIVOT trial, the trials from Europe, looking at watchful waiting versus active surveillance, and then long-term outcomes after surgery in the PSA era became available. So this is the PIVOT trial, but basically there's a few other trials, and it shows that in low-risk patients, again, confirming that at least in the PIVOT, I think it was just radical prostatectomy, not radiation therapy, but those men with low-risk disease really gained no benefit. Some men, and again, this was the lumped-in intermediate risk disease, those with unfavorable intermediate risk are those likely to gain benefit. And then high-risk patients certainly did gain a benefit from treatment. So again, confirming that active surveillance should be used in lower-risk patients, some intermediate risk patients, and then treat high-risk disease. And so that led to what we do now. We manage the majority of men with low-risk prostate cancer with active surveillance. Some of the favorable intermediate risk are also treated with active surveillance. And now we operate essentially on everything else except bulky disease. So with surgery, there are appropriate concerns about using radical prostatectomy in men with higher risk features. And those include the age-old oncologic and quality of life issues. From the standpoint of intraoperative complications and rates of incontinence, stage really doesn't impact that. So someone who is low risk that underwent surgery has similar rates of intraoperative complications to someone with high risk. We're not talking bulky disease. We're not talking about big clinical T3s, T4s. But those who are considered surgically resectable, intraoperative complications and continence recovery basically are stage independent. Of course, these patients do undergo wider resection. Rates of erectile dysfunction are higher than those men with less risk disease, but certainly it's not inevitable that everyone develops erectile dysfunction. This is our small series, a few hundred men in the that had been followed for a couple of years, but a little less than half did recover erectile function defined as an IIEF of greater than 21. So it's not inevitable that the patient has erectile dysfunction, but it's certainly a higher risk compared to those patients with more favorable disease. And then, of course, there are high rates of biochemical recurrence. And an argument that's often used in against surgery in this setting is that, well, everybody's going to need radiation therapy anyway, so why don't you just use radiation up front? Not a real argument. More men, compared to intermediate risk, certainly will, but at least half the patients are cured with surgery alone. And many of those men that fail can be salvaged with radiation therapy. So certainly surgery provides a reasonable, or maybe better said, not unreasonable chance of cure in the high-risk population, but many patients will ultimately go on to salvage therapy. But prostate cancer-specific mortality in the high-risk population is still excellent. At 15 years, 19% of patients have died of their prostate cancer. 31% have died of other causes. So while biochemical recurrence rates are about 50%, dying from prostate cancer occurs at a much lower rate. So surgeons aren't happy with 50% of their patients recurring, so we've tried a number of strategies. Now, one of the things that radiation oncologists, there's many things that radiation oncologists do better than surgery, but one of the things they do much better than surgeons is clinical trials. In the surgical world, we have not been very good at doing clinical trials. But multiple studies have looked at relatively short course neoadjuvant standard ADT for up to 8 months. None of those studies have shown a meaningful improvement in outcomes. There have been some pathologic benefits, lower positive margin rates, but BCR, clinical recurrence, survival, et cetera, were not improved with at least up to 8 months of ADT. Whether longer-term ADT would benefit, no clue. But at least that's the state of the art. And for those patients with high-risk disease undergoing radical prostatectomy, we do not routinely use neoadjuvant treatment. There have been and are a number of ongoing trials looking at other therapies, non-hormonal based agents, the concept of androgen annihilation, and ultimately tailored medicine, if you will, based on genetic studies. So the non-hormonal based strategy, and this was a tedious trial to do. The Alliance started this trial back in 2002 or 3. It took 15 years to accrue. And it was basically men with high-risk, clinically localized high-risk prostate cancer. And they were randomized to either neoadjuvant chemohormonal therapy with docetaxel and standard ADT versus surgery alone. The primary endpoint was biochemical recurrence-free survival at 3 years, and that endpoint was not reached. So it was a negative trial in terms of its primary endpoint, but there were other secondary endpoints that were achieved. So overall, meaning not simply at the 3-year mark, biochemical recurrence-free survival was improved. There was far less need for salvage therapy in those patients who had received neoadjuvant chemohormonal therapy than those who had undergone surgery alone. The number of deaths were very low. So if you flipped a death here or there, it certainly would change my next statement. But there was an overall survival benefit for those who received multimodal strategy than those who received surgery alone. And certainly I don't think we can throw away neoadjuvant docetaxel or neoadjuvant chemotherapy in this space. I'm not sure if we'll ever do another study like this, but it's a consideration for some patients. The concept of androgen annihilation, I think Mary Ellen Taplin gets most of the kudos for this. My slides are a bit dated, but basically the concept of using not only standard ADT, but other androgen receptor inhibitors, and looking at pathologic endpoints. Now, one can argue whether this minimal residual disease is a meaningful endpoint. It seems to be. It hasn't been proven yet. But if you look at pathologic complete responses and this minimal residual disease category, we were seeing rates of up to about 30%, which we had not seen in the ADT neoadjuvant strategies, and we certainly did not see complete responses in that Alliance trial looking at docetaxel. So perhaps the concept of multiple androgen impacting medications, let's just put it that way, will have a benefit. And there's a big phase 3 trial that's going on right now. And then the final concept is genetic guided therapy. It's called the GUNS trial. I like that. And it's led by Marty Gleave at British Columbia, University of British Columbia. And it basically takes men with clinically localized high-risk prostate cancer. They're all treated with standard ADT and apalutamide. And then they undergo genetic profiling. And based on their profile, they'll basically fall into one of 4 groups. And then based on the group that they're assigned to, they will be randomized to a particular strategy or designed to go on a particular strategy. So there are a small number, or there is a small number of folks who will have what are called immunogenic cancers, and they'll get immuno-oncology, et cetera. The PARP inhibitors we've talked about, the DNA damage, et cetera. So this is a strategy that I'm hopeful will be useful in terms of managing clinically localized high-risk disease. So I think what we can say today is that certainly local therapy is an accepted first-line treatment. Some men will opt for radiation plus hormonal therapy. Others will opt for surgery, and that's an individual conversation with patients. We know that at least in the surgery world, local therapy alone is often inadequate, and we're exploring neoadjuvant and some adjuvant studies. And certainly it's likely, as with many other cancers, that a combination of treatments surgery, radiation, systemic therapy, hopefully with guidance from our laboratory colleagues to help sort out who will benefit most from what. So thank you very much.